Welcome back to our totally optional shoulder case. By the end of this podcast, you should be able to recognize that shoulders get various arthropathies, be able to list some key clinical and radiographic findings of shoulder arthritis, and be aware of the utility of shoulder replacement surgery. So meet Art and Betty, a vibrant older couple. They have a couple of bad right-sided shoulders and have managed to get consecutive consultations at the shoulder clinic. Their primary care provider has followed the treatment staircase, which shares a substantial overlap with lower extremity arthritis. Physio hasn't helped, and corticosteroid injections stopped working for them a while ago. You'll recognize some common features of arthritis, such as grinding, night pain, and stiffness. Art can't recall if he's had dislocations of his shoulder back in the day. And it's noteworthy that Betty has a history of rotator cuff trouble and that she has to drag her right arm around with her left. Otherwise, their activity goals are modest and reasonable. Their clinical exams show some differences. Art has similar active and passive range of motion, while Betty shows a gap between active and passive range of motion. Betty's rotator cuff is largely deficient, while Art's is pretty much intact. You've seen this slide before, and this is our reminder of what normal looks like. This is Art's shoulder. You'll note all the usual findings of osteoarthritis apply. So we've got joint space narrowing, subchondral sclerosis, osteophytes, and subchondral cysts. Shenton's line is pretty much conserved. Shoulder osteoarthritis is particularly characterized by very large inferior osteophytes. This is Betty's shoulder. You can see that joint space narrowing and subchondral sclerosis is evident, but this is a much different situation. Shenton's line is obviously disrupted, the greater tuberosity is gone, and there's not only no space between the humeral head and the acromion, but the acromion itself is nearly completely eroded. This is a classic example of the arthritis that develops with chronic massive rotator cuff failure. The best x-rays to assess shoulder arthritis, in my opinion, are the AP glenoid x-ray and the axillary x-ray. By way of being a bit cheeky here, should we fix Betty's rotator cuff tear? In the end, it's clear both need shoulder replacements to achieve their goal of pain relief. They're in good health with reconstructible shoulders. One thing you'll note when dealing with older persons, especially couples, is that the order in which things get done becomes something of a negotiation, because each patient will need a caregiver, and there may be multiple steps involved. So what other preparations do we need? This table gives a quick review of the usefulness of various imaging. One thing we have to consider in shoulder replacement surgery is the three-dimensional anatomy of the glenoid. It can erode unevenly, and this is harder to characterize on regular x-rays. Although it's tempting to jump straight to the MRI, there's no good reason for the MRI to be the first study to diagnose advanced arthritis. It's not a good use of resources. So the most efficient and resource-effective imaging is a combination of good x-rays and an ultrasound interpreted in the context of history and physical exam. If the patient is moving towards surgery, getting a CT scan is a good idea. It's not important to know the nuances of shoulder replacement, but there are two broad categories depending on how the rotator cuff is doing. These are examples of each. We've covered the two most common shoulder arthropathies in Art and Betty. This is a quick summary of the other joint pathologies that will appear in shoulder clinic. Unless you're looking to a career in orthopedic surgery or rheumatology, you do not need to fuss over this slide. So Betty and Art are now more than a year post-surgery. They're each feeling good and achieving their goals. Their mobility is average to good post-replacement. On the right, some summary take-home points about shoulder replacement. It's not as common as hip and knee replacements, but it's still a successful operation. The state of the rotator cuff dictates the clinical features and the treatment. Unlike hip and knee arthritis, additional preoperative imaging is needed, and patients don't typically gain a lot of range of motion with their replacements. If you're in primary care, the key here is to call this arthritis when you see it and to know that effective treatment options exist. This is really rewarding surgery and adds materially to patient quality of life, but only if they get referred. If you do end up with questions about this content, please reach out to me via chat at the live Q&A. It will take a bit lower priority than questions on core content, but I'll try to address questions on shoulder arthritis either at the time or by email after, so make sure you add your address after any chat questions.